So I'll give you your lecture for the retina and vitreous today. So let's begin. So let's begin first with the embryology of the retina. So first, you have the neural tube. So this is the neural tube. So as the neural tube closes, the optic pits or optic groove forms and it deepens to form the optic vesicle. So the vesicles are symmetric, hollow outgrowths on the lateral sides of the neural tube. And the vesicles is remainly attached on the neural tube by the optic stalk. So you have the optic stalk, this one. So as a double-walled optic cup now forms, so this is the double-walled optic cup that has the inner wall and the outer wall. So this will become the inner wall and the outer wall, alongside with the invagination of the optic vesicle. So as the optic vesicle approaches the outer wall of the embryo, a focal thickening of cells happens and the lens, your lens, develops in the surface of ectoderm, forming the lens vesicle. So later on, you will know that the inner wall of the optic cup would become your neurosensory retina, while the outer wall of the optic cup would become your RPE, or your retinal pigment epithelium. So this is the optic cup. The outer layer of the optic cup evolves as a monolayer of cells to become the RPE, or the retinal pigment epithelium. The inner invaginated layer will become the neurosensory layer, or neurosensory retina, or will become the 7 layers of your retina. The 2 layers optic cup would have a small space between them, so this one, which we call your optic ventricle. As invagination continue, the inner and outer layer become attached, and the cavity of the optic ventricle progressively narrows. But still, there is a potential space between them. So the ventricle cavity remains throughout life as a potential space, or your subretinal space, that explains a possible disease of retinal detachment. The inferior portion of the cup, this one, is initially incomplete. The indentation or fissure between the folds or margins of the cup is the embryonic fissure. The embryonic fissure allows vessels of the hyaloid system to be incorporated within the eye. Closure begins in the mid-region of the cup near the equator of the globe and proceeds anteriorly to the ring, posteriorly downward to the stalk. And when the closure does not happen or is incomplete, a congenital anomaly called coloboma, like this one, so as you can see, there is an iris defect, or sometimes there's also a defect on the lens. So we call that iris coloboma or lens coloboma. On the retina, you can also see the coloboma, or we call that retinochoroidal coloboma as this one. It's a deep excavated area on the retina. So as you would know, it is usually on the inferior. So this is due to incomplete closure of your embryonic fissure. So why does the eye has potential of having retinal detachment? Because of there is a potential space between the neurosensory layer and the RPE, which is on embryonically, that's your ventricle, optic ventricle. So let's review the anatomy of the retina. So this is a sagittal picture of the eye. This is the anterior segment comprising your what? Your cornea up to the lens. So the retina belongs to the posterior segment along with your vitreous, choroid, and of course your optic nerve. So the retina is considered to be the camera of the eye. So when the retina is magnified, this one, you see the layers, the 10 layers of the retina where most of the light to electrical signaling happen for us to see images. So this is the fundus photo or picture of the right eye. So how do you know that this is the retina of the right or left eye? So how will you know that if it's this is the retina of the right or left eye? And is this normal or abnormal retina? Is this a right eye or left eye? Is this a retina of the right or left? So this is the right eye, no? Retina of the right eye. Why? How do you know that it is the right eye or right retina? So because in describing the retina, of course, you would start by knowing the laterality. So this is the right eye. Why? How do you say that this is the right eye? How do you identify if this is the right eye?
Based on the optic disc.
Yeah, so the optic disc is located usually where? Aside from yeah, there's a um, label there that this is a right eye. But as a medical student, you should know um, or you should know if it's the right eye or left eye. So because of what? Ano yung sinabi mo? Because of this is the right eye because anyone. So because so usually temporal yung macula and the optic nerve is usually nasal. So usually the optic nerve is seen medially. So your nose usually medial. So usually the optic nerve is not on the center naman of the retina. So it's usually medially. So if this is the left eye, you will see the optic nerve here. So this is a normal retina. First describe the clarity of the fundus. So you see this clearly. You describe the optic nerve, the retinal vessels, or any gross lesions if you see any. So you describe this retina as this is a fundus photo or fundus of the right eye seen in a clear media with distinct this margin with cup to this ratio of around 0.4, 0.4 with normal course of the temporal vessels. So these are your temporal vessels. Nasal vessels would be here. So normal course of temporal vessels. There's no tortuosity or dilatation. The artery to vein ratio, artery, this is the vein, is around 2:3. So that's the ratio, normal ratio. In hypertensive retinopathy, it's around 1:3. So medyo narrowed ang mga arteries on hypertensive patients. You see no exudates and no hemorrhages seen. This is a normal foveal reflex. You see this one, this is normal. So this is a normal retina. So the macula, also known as the posterior pole or macula lutea central retina or area centralis, is 5 to 6 millimeter in diameter, bounded by your temporal arcades with 2 or more layers of ganglion cells with abundant antioxidants, which are your lutein and zeaxanthin, that filters the harmful blue light, preventing photic damage on the retina. So at the center of the macula is the fovea, or the fovea centralis. Around the measurement would be around 1.5 millimeters, which is specialized for high spatial and color vision. At the center of the fovea, so ang fovea usually measures similar to your optic nerve. This is around 1.5 millimeters also. At the center of that would be the FAS, or your foveal avascular zone, which is devoid of vessels. So what photoreceptors? So you know the photoreceptors of the retina, right? So what are the photoreceptors that I'm talking about? So the rods and cones. So in the fovea or on the macula, what photoreceptor is usually abundant here? So usually sa foveola, that's the central tip of the FAS, around measuring around 0.35. So where rods or cones are abundant compared to the peripheral retina. So on the macula or on the fovea, what photoreceptor is abundant? Ano? What photoreceptor is abundant? So usually cones. Cones are abundant on the macula or the FAS or fovea compared to the rods, which are very abundant on the periphery. And so these are just a measurement of the retina, not no need to know them. So this is the fovea. After the fovea, the parafovea, around 0.5 millimeters after the fovea, and the perifovea, or the peripheral macula. So it's very important, the name of the parts of the retina, because we describe that. Whenever we describe or we see any lesion, we locate them and we describe them based on their location. So, but on your part, what's more important would be the layers. You should know the layers of the retina. So this is just histologic section of the retina. So depending on you, you can make your own acronym for you to remember them. So from inner to outer layer. So you can use this acronym, the in, ipin, upon. So I would be your internal limiting membrane, followed by your nerve fiber layer, your ganglion cell layer. I'm sorry, so this would be the ano pala. So inner, ILM, nerve fiber, followed by ganglion cell, your inner plexiform, inner nuclear, outer plexiform, outer nuclear, your photoreceptors, the inner segments of your and outer segments of your photoreceptors, followed by your RPE, or retinal pigment epithelium, and choroid. So better to know the layers from the inner to outer layer, because most of the lesions that we see on the retina, their configuration would really depend on what layer they are found. So we'll tackle that later on. So let's review the visual cycle, or the processing of vitamin A. We know that vitamin A is important in the visual cycle. So first, the enzymatic processing within the visual cycle begins with delivery of the vitamin A. So with your vitamin A as all trans retinol from the blood to the from the blood circulation. So upon entry of the vitamin A into the RPE, the all trans retinol is converted to retinol esters through the activity of lecithin retinol acyl transferase. And this all trans retinol ester pool would represent the storage form of your vitamin A, upon which your RPE 65 would act to generate the 11-cis retinol. So your 11-cis retinol is then oxidized by the 11-cis specific retinol dehydrogenase to form the visual chromophore, the 11-cis retinal. The visual chromophore is delivered to the rod and outer segments of the photoreceptors, where it becomes with where it combines with your opsins to form the visual pigment or rhodopsin. The light activation of rhodopsin initiates visual transduction processes and liberates the all-trans retinal as a photoproduct. The reduction of your all-trans retinal via your all-trans retinal dehydrogenase produces the all-trans retinol, which is transferred back to the RPE for recycling. So the continued activity of your RPE65 in the light state ensures that sustained levels of rhodopsin and closure of ion channels through transducin activation and reduced oxygen demand. So the storage form of your vitamin A is what? Your all trans retinal esters. So in the retina, the photoreceptor synapse directly into the bipolar cells, which in turn synapse onto the ganglion cell of the outermost layer, which will then conduct action potentials to the brain. So at baseline, so in the dark, the rhodopsin would absorb no light and releases glutamate, which inhibits the bipolar cell. This inhibits the release of neurotransmitters from the bipolar. From the bipolar cells to the ganglion cell. However, when there is light present, the glutamate secretion stops, thus no longer inhibiting the bipolar cell from releasing neurotransmitters to the ganglion cells, and therefore an image can be detected. So now let's review the blood supply of the retina. So this is very important. The central retinal artery, which is the first branch of your ophthalmic artery, which is what branch, Ophthalmic artery is coming from what branch? Your ICA, your internal carotid artery, which will then, your central retinal artery would enter the eye and splits into 4 branches, each supplying the blood to a quadrant of a retina located in the inner retina. So very important that central retinal artery would supply the inner 2/3 of the sensory retina. So from nerve fiber hanggang here. Inner 2/3 of the retina. Outer 1/3 from the outer portion of the inner nuclear up to the RPE would be your choriocapillaries. So outer portion ng outer nuclear up to the RPE would be supplied by your choriocapillaries. So usually 2 blood supply ng retina, your CRA, central retinal artery, and your choriocapillaries. So your choriocapillaries supply your outer 1/3 and your fovea. So your choriocapillaries is a capillary system of the choroidal arteries that branches from ciliary arteries. So very important later on that based on the especially in the disease called their central retinal artery occlusion, you would note that why the fovea is very more evident. So there is whitening of the retina. So because the fovea is the supply of the blood supply of the fovea is different. So it's supplied by your choriocapillaries. So the 2-layer capillaries, the 2 layers of capillaries supplying your retina would be your superficial capillaries, supplying your GCL or ganglion cell layer and your nerve fiber layer. However, you also have deeper capillaries supplying your inner nuclear layer. So ang blood, the venous system, very simple. It's from your central retinal vein. So your blood collected from your capillaries will be accumulated within the branch retinal vein, which in turn forms the central retinal vein. So normally, the blood vessels of the retina is transparent. However, it appears bright red due to oxygenated blood. And the retinal vessels has non-fenestrated endothelial cells. So very important to know that it is non-fenestrated with tight junctions and is considered to be the inner blood retinal barrier. So your retinal blood vessels is considered to be the inner blood retinal barrier. And the retinal vein on the nerve normally pulsates. However, in cases of central retinal vein occlusion or papilledema, with you have increased intracranial pressure, there would be absence of the venous pulsation. The pulsation is caused by variation in the gradient or pressure gradient along the retinal vein as it traverses the lamina fibrosa in the optic nerve. An increase in intracranial pressure, like in your papilledema, the venous pulsation stops because of the increased ICP, intraocular pressure, or intracranial pressure, rather. So the arterial blood supply of the retina, so which statement is correct? A, central retinal artery supplying the inner two-thirds. B, choriocapillaries supplying inner two-thirds. C, central retinal artery supplying the outer one-third. Choriocapillaries supplying the RPE. So what's the answer? Yeah, so the answer is, the correct answer is A and B. No? So, syempre, A, central retinal artery supplying the inner two-thirds, and B, supplying the choriocapillaries supplying your RPE. So, very important to know the blood supply of the retina. So, para may 1 point naman na kayo. Next, very important structure of the retina would be your RPE, or your retinal pigment epithelium. So it is intimately related to your photoreceptor cells. Basic functions of your RPE include, first, phagocytosis of your photoreceptors, responsible for vitamin A metabolism, for the trophic, hypertrophic, or hyperplastic response to any disease. It heals and forms scar tissue, and it maintains the subretinal space. It maintains the dehydrated state of the subretinal space. Normally, there should be no fluid in there, so that's the job, or the that's the function of the RPE. So question, the functions of RPE are the following, except A, phagocytosis of photoreceptors, outer segments. B, inner blood retinal barrier. C, it absorbs light. D, for vitamin A metabolism. Answer is B. Bakit? Why B? Why B? Because, so RPE is the outer blood retinal barrier. So the inner blood retinal barrier is the what? Is your inner retinal blood barrier would be your what? Your retinal vessels. Your endothelial cells of the retinal vessels. Pag outer blood retinal barrier, that's your RPE. This one. So remember this. The following is true about the macula, except A, it's bounded by your superior and inferior temporal arcades. It is also termed as your posterior pole or central retina. It has few antioxidants like your lutein and zeaxanthin. Its center is specialized for high spatial acuity. So why C? Why C? So bakit mali yung C? Yeah, so it's usually abundant. So it's not few. So usually abundant. So there are specific symptoms that would signify that the complaint or um, the structure that has a problem in the eye would be it's all about the retina or your posterior segment. So the normal symptoms that they complain, usually there's blurring of vision, either it's painful or it's painless. So, but in retina, usually it's painless. So the visual disturbance without pain, you can either differentiate them if there is cone dysfunction or rod dysfunction. If there's cone dysfunction, usually at the center of the macula, you have reduced visual acuity, you have impaired color vision or metamorphopsia. So the patient will see this one, distortion on the vision or scotoma. However, if there's rod dysfunctions, as we all know, rod is more abundant in the periphery, there could either be night blindness. What disease would be associated with night blindness? What disease would be associated with night blindness or nyctalopia? You have night vitamin A deficiency. What else? Yes, very good. Vitamin A deficiency. Ano pa? Yung, it's one of the triad of this disease. Nyctalopia, night blindness. That's your retinitis pigmentosa. So if you have impaired peripheral vision, or maybe you have rod dysfunctions. So very important to know, cones are abundant on the center, on the periphery, rods are more abundant. Very important symptom of the retina would be photopsia. Photopsias are reflection of the eye in which the patient perceives luminous rays or flashes of light. It is usually a result of traction caused on the retina. So if there's a traction causing pull on the retina, as we all know, the retina has photoreceptors. That's the reason why there is flashes of light perceived by the patient. Floaters may also result from opacities or hemorrhages in the vitreous. So any opacities that is within the vitreous cavity would sometimes perceived by patient as floaters, or blurring of vision resulting from opacities in the ocular medium. Retina function. The function of the retina can be determined by the following. Very important, the visual acuity, using a Snellen chart or ETDRS chart. Color vision, we use these plates, the pseudo-isotochromatic plates or your Ishihara plates. Dark adaptation test, which is quantified by measuring the recovery of the retinal sensitivity to low light levels over time following a stance period of bright light exposure. Or ERG, or electroretinography measures the electrical response of the retina to flashes of light. The commonly requested diagnostic test to determine the retina function would be your fluorescein angiography, wherein we put a dye on the vein of the patient and we take a picture of the fundus or the retina. So this is an example of a fluorescein angiography to detect the vessels or the caliber of the retinal vessels. So disturbances of retinal blood vessel could either be venous dilatation, hemorrhages, you can see hemorrhages, microaneurysms, neovascularizations, or exudates. You can see this as very evidently by doing a fundoscopy. So either indirect or direct ophthalmoscope, you can see hemorrhages very well. You can describe the vessels, the retinal vessels. So for venous dilatations, as you can see, this is an abnormal. I already showed you a normal picture of the retina. So this is very abnormal. You see dilatation and tortuosity of your posterior vessels. This is venous beading or venous loop. You see the omega sign. Venous beading, it's like sausage shape. There are sort of segmentation on the vein. This one also, like this is venous beading, very typical to be seen in diabetic retinopathy, retinal arteriolar obliteration, so is this ischemic vessels. However, in venous dilatation, you see these signs in increased venous pressure, blood hyperviscosity, hypotony, low intraocular pressure, diabetic retinopathy, central retinal vein occlusion, or vascular tumors of the retinal blood vessels. Hemorrhages. So there are different types of hemorrhages in the retina. So the topmost picture here is your pre-retinal hemorrhages. The location is between the retina and the vitreous. So it's usually both shaped, or we term this a meniscus sign. Plane-shaped hemorrhages, usually the location is on the nerve fiber layer. So it's parallel to the nerve fiber layer, so it's usually feathery. The hemorrhages, the edges of the hemorrhages are irregular. So this is a case of branch retinal vein occlusion. So you see the hemorrhages on the inferior or on the superior half of the macula. Dot blood hemorrhages, very typical to be, you see that in diabetic retinopathy. These are round hemorrhages. It's either can be small dot or a blot. Blot would be a bigger hemorrhage, or like an egg blot. So the location of dot blot hemorrhages is a little bit deeper on your inner, could either on the inner or outer plexiform layer up to the outer nuclear layer. Just remember, plane-shaped hemorrhages would be on the nerve fiber layer. Pre-retinal hemorrhages between your retina and the vitreous. So this is just a cross-section, no? As just like what I told you a while ago, remember the layers of the retina. So pre-retinal layer, it's just here. It's already on the vitreous, on top of the retina and between the vitreous. If it already traversed the vitreous, it's already here, it would be vitreous hemorrhage. So if it's just between them, between the vitreous and the ILM or internal limiting membrane or the retina, that's your pre-retinal hemorrhage. If it's parallel to the nerve fiber layer, you would see them as plane-shaped hemorrhage. If it's deeper, from inner nuclear to outer nuclear, that's your dot blood hemorrhages. Exudates is also seen very commonly on your outer plexiform, or any edema would be on the outer plexiform layer. Fluid accumulation would usually be an outer plexiform layer. Microaneurysms seen as minute dots or red dots. This one is very small, very typical in diabetic retinopathy. So this is caused by outpouchings of the venous side of the capillary network, where it leaks plasma and exudates. So usually where the exudates are, that's where the microaneurysms are. So sometimes we do laser on this leaky microaneurysm so that it will not produce secrete or excrete exudates or edema. So where do you see microaneurysms? Very common in diabetic retinopathy. Also still on venostasis, vein obstruction, Coats disease, erythroiditis, or hyperviscosity. Neovascularization naman, these are abnormal blood vessels, abnormal new blood vessels that are very fragile and are thin in caliber that easily breaks. So very important lesion in proliferative type of diabetic retinopathy that can easily rupture and cause hemorrhage or vitreous hemorrhage. So these are the disease that can also produce neovascularization in the retina. So unlike the normal retinal blood vessel, they are very fragile, so they are abnormal. Retinal deposits, we call them exudates. We have hard exudates and soft exudates. So soft exudates would be your cotton wool spots. These are white lesions on the retina with irregular borders. Hard exudates are more solid and more they are regular, more solid looking. These are composed of your fats or usually proteins, lipoproteins. And these are from localized areas of your retinal edema. So usually where the exudates are, there could be edema. So usually they are associated with diabetic edema or macular edema. So the patterns could either be circinate or there can be confluent, foveal star, or scattered. So these are soft exudates, the cotton wool spots. They have indistinct white retinal opacities with hazy irregular outline. What layer? Again, it's in the nerve fiber layer. Pair of hard exudates, they are deeper, usually on the outer plexiform layer, outer nuclear layer. Soft exudates, because it's irregular, feathery, medyo ibabaw, or more anterior, they are from the nerve fiber layer. They are accumulation of cell organelles and reflect obstruction of their axonal flow in the nerve fiber layer. So they are usually associated with ischemia. Opacities of the sensory retina, you'll either see opacities in the media, inflammatory exudates like in vitritis or uveitis, posterior uveitis. You can see retinal deposits, hemorrhages on the vitreous, membranes in traction membranes in diabetic retinopathy, or this one, the opacity on the retina or detachment of the retina, you see them as opacities on the sensory retina. So flame-shaped hemorrhages occurs at what layer of the retina? Answer. So yeah, where I always reiterate, it's from the nerve fiber layer. So B. Diagnostic test used to evaluate the retina microcirculation or your retinal blood vessels. So we've tackled this already on the first few lectures. No? So it's A, Fluorescein Angiography. OCT of the macula is used to know the layers of the retina. So you would see the histologic cross-section of the retina. So very that's the commonly requested test in retina evaluation of the disease. So your FA and your OCT. FA if you want to know the vessels or the retinal vessels. OCT if you want to know where the layers of the retina. B-scan ultrasound, we use that if there is significant medial opacity such as cataract or vitreous hemorrhage, or cataract or corneal opacity that you want to evaluate the posterior segment, you can use B-scan ultrasound. However, the retinal details, you can see it on ultrasound. It will just show you if there is any opacities or membranes in the vitreous cavity. Specular microscopy usually detects the number of cells in the cornea. So it's not related to retina. So we'll just tackle some of the topic on vitreous. So as we all know, vitreous is also part of the posterior segment. So vitreous is usually avascular. So it's a clear gel at the back of the eye, around 4.5 milliliters. It's avascular. It's usually like this, gel-like. It is usually composed of most of water, 99% water, 1% collagen, and few of hyaluronic acid. It's 2/3 of the volume of the eye, so it comprises major part of the volume, eye volume. The base of the vitreous, somewhere here, is where the has firm attachment. So usually most of the tears happen on the base of the vitreous because there is firm adherence of the vitreous here on this part. Kaya you see most of the tears here. It is in the vitreous is in contact with your retina and helps keep it in place by pressing it against the choroid. So the vitreous is usually produced by the cells in your non-pigmented portion of your ciliary body. So remember, it's non-pigmented portion of your ciliary body, which is derived from your embryonic mesenchyme, which normally degenerates after birth. So there are few diseases of the vitreous. Vitreous hemorrhage is not included because the main pathology in vitreous hemorrhage would be the retina lesions or retina disease. So there are some opacities or usually the vitreous degenerates as you age. Especially in myopes, with those with long eye, nearsighted, they usually are the ones who complain most of floaters. So because their vitreous usually liquefies fast, we call it liquefaction or syneresis. There could be earlier vitreous detachment. So it's normal to have vitreous detachment or vitreous shrinkage. And the complaint of patient would be sometimes usually floaters, so that usually moves, unlike scotoma that it's usually permanent on the center. But in vitreous, floaters usually moves. Vitreous floaters usually moves on different gazes. So it's usually benign, and we don't treat it. So we just advise the patient to, because these floaters will be very evident when you have bright lights. So especially when you're driving, you see them. So it's better to dim or reduce the contrast or dim light so that it will not be that evident or the patient will not be bothered with this floaters. But technically, there is no eye drop or no treatment for that. Although in other countries, they do vitreolysis. It's a laser that parang disintegrate these floaters. Vitreous opacities can either be hemorrhage, just like in diabetes, or there's holes, retinal holes, wherein you're able to rupture the vessels. That's why it produces hemorrhage. Asteroid hyalosis or syncytial scintillans, depending on what component it is. So we call it asteroid hyalosis if there is calcium. Syncytial scintillans if it's the component is cholesterol. So, but they look the same, and it's not. We don't do anything. It doesn't cause much blurring of vision actually. So operating this kind of disease is not really indicated. So most of my patients usually don't complain much of the blurring of vision. So usually these are just incidental findings when you see them. True about vitreous, except A, is it clear, clear vascular gelatinous body? B, it forms 2/3 of the eye volume. C, it's mostly water and 1% collagen. D, it's produced by non-pigmented portion of ciliary body. Answer is yes, so very good. So it's clear in it, it is avascular. What other part of the eye is also avascular? So aside from vitreous, yeah, very good. So lens, your lens is avascular and no nerves, so it's usually not painful. So lens and vitreous is usually avascular. And also your cornea pala. Cornea, usually avascular. Okay, so we will stop here. We will continue with our retina lecture next week. So we will tackle more of the retina diseases. And there are a lot of diseases in the retina, but we will just emphasize the important ones, that as a medical student you should know. And very common, the diabetic retinopathy, it usually overlaps with your other subjects like your pathology, pathophysiology, internal medicine. So that's the very important and very common here, common disease, common retina disease. And then before we will proceed with the lecture next week, we will have first your exam, your long exam, because you just have two more long exams, right? So after your third long exam, you'll have your final long exam. Maybe I'll also give you a short quiz if we have enough time. I'll remind you again, I think you have your orientation with Dr. Rafael, I think, on Saturday, which was postponed last Saturday, diba? So, yeah. And after that, any suspicious actions that you will do during the mga few exams natin, I will not reconsider it. Okay? So I posted an attendance sheet pala there, so I can note of your attendance. Any questions? So yeah, so we'll have your long exam next week. So I'll maybe around 1:15. So attend the orientation with Dr. Rafael. Okay. Thank you.